I'd like to welcome everyone to what we hope is an annual ePRO conference. I am Tom Henson, Vice President of Marketing, and would like to welcome all of you. Thank you for taking time out of your busy schedules to attend this event. We have put together what we hope is a educational, informative agenda, and we hope to keep this as a interactive conference with lots of dialogue and conversation.
So then when we start to think about how to actually perform our clinical trial, we have this question, so how are we going to implement this? Is it on paper or is it on electronic diaries or IVRS? And I'm struck by the fact that there are still a common view, at least within my company, that ePRO, it's nice, but it actually adds to cost and time. I think that, I actually thought that you would show all the slides, you know, showing all the benefits. I guess most of us know that already. I think that to us as scientists, I don't really care so much about time and cost when I've seen how much better the data quality is and what that does in terms of, as you alluded to sample size or reduction in sample size or increased power. And when it comes to that, if we as a sponsor have to show the regulators that the assessments were done according to the protocol, there is no way we can do that with a paper diary, because all of us know what happens at home when patients, we don't know when they performed it. We actually don't know who did it. But we have some good data to indicate that they don't do it when we want them to do it. So I think this is one of the main drivers why I would never, ever consider performing a trial based on paper diaries anymore. Some of the things that are very important, at least to me, I think, is the way that patients cannot go back and forward and fill in prospectively or retrospectively. There are missing assessments in diaries, of course, too, but at least we have control of them. We know that it's a true missing assessment. The timestamp, extremely important. At least when we look at our data, we also see that we have less missing values within an individual assessment on e-diaries than on paper. And for those who are working within data management, I think it's good news that patients cannot change the response options or change the question because it didn't seem relevant at the time. And we don't provide them with the opportunity of giving a full list of what they've done during the past years that we have to code and interpret and maybe check that it's not a serious adverse event.
So in that phase 2 program, we learned quite a few things, and this is what you're supposed to do, I suppose, with phase 2. You learn things that you implement in your pivotal programs. We learned that patients were quite compliant with this approach. The fibromyalgia patients were very willing to fill out these electronic diaries. We didn't really have significant compliance programs in general. Compliance problems. Occasionally you'll get a patient who doesn't want to do it, but that is the exception. So here's what I would call the traditional data, and this is from actually something I showed the FDA after the end of this trial. I said, if we did it traditionally where we have paper and pencil VAS scales filled out in the clinic during physician's visits, this is the information we know about this patient's 3 months experience on our drug. They came in and they said a score was here, and this is a 0 to 20 scale because this is that logarithmic Gracely scale. So they came up here with pretty high pain score, and then they came into the clinic 3 subsequent times later after being on drug, and they recorded a score down here, so that looks like a pretty good change. But we really have no information about what happened during this period. Was this just a straight drop? Did they go up and down? You just don't know. And then this looks really nice and flat, like they had no change. You got them to a stable point, it didn't change. And you really don't know if that's true also. All you know is that when they came to the clinic, they tended to record the same score. So that would have been the classic data that you would typically run, and probably 2/3, 3/4 of all pain trials the FDA has ever had filed were collected in this way. So this is what they're used to. So then we started showing them some of the types of data we could provide. This is that same patient's weekly diary pain scores, and you can see it actually is a pretty good example because she had a pretty good response, but she had a little bit of variability around baseline, but not a lot. She was fairly consistent in how she recorded her baseline. About week 3 was where she started getting dosed with the drug. And then you can see there's a fairly good response, but it does take a few weeks. Comes down, and then when she was terminated, this is an interesting point that you don't see in the paper VAS. When she was terminating from the trial, when she knew she was exiting the trial and would no longer have access to the study drug, she starts reporting increasing pain prior to going off the drug. And we see that fairly typically when we don't have an extension trial, when we don't have the opportunity for patients to stay on a study drug. They will tend to flare at the end knowing it's going to end. Whether or not their pain is really changing, that anticipation will affect your results. So you do have to think about timing of your primary endpoint relative to when they go off drug, and you do have to think about if there's something for them after you take them off your double-blind study, because it will affect your conclusions. And then this is actually, unfortunately, a different patient. I couldn't find the same patient in this presentation format. This is another patient from that same study with the random prompt pain score. So now you can see the sort of detail you can get during baseline, during dose titration, and during the follow-up phase when they're on a steady dose of the study drug, giving you an idea. And this looks like a very nice, stable patient. I'm going to show you some profiles in a few minutes of people who are not this easy to describe. But again, you have a lot more confidence. You understand what's happening with this patient when you have this type of data than when you have the 3 or 4 data points you would classically get with paper and pencil pain. So having said all this, it was pretty easy to convince the FDA that, gee, this looks better. This looks like you'll have a better feeling for the pain response of your patient population with this approach than we would with traditional methods. One of the things we noticed
would affect my sample size.
So I'll be provocative then. So then what's the ROI for using ePRO?
quality. As I said when we started, I did it for quality reasons, not for money reasons.
Yeah, I mean, I totally agree. I mean, the presentation that we just heard was very good, but it, in a way, I almost at times thought that they were equating EDC with ePRO as if they were the same thing. I mean, you were just getting electronic data, from both, and I see them as totally different things. I mean, I really see a benefit from EDC, but I would, that would be far, I would consider that far less than I would ePRO. I would never not use ePRO because ePRO is, the quality of the data is so much better. I mean, if you've got patients, sitting at home, filling out whatever the, paper diaries whenever they want, filling them out ahead, filling them out back, filling them in the parking lot. I mean, I just don't trust that data. Whereas when you've got ePRO, be it all the problems that you have, you know what you've got. You actually have data. And whereas the EDC stuff is filled out by the vendors at the sites, it's filled out by the people that you've hired. So, it might be better data, but it's not significantly different.
Right, I agree with that.
Jean, can I just comment on
Absolutely. Yep.
And when it comes to to me, it's from a company perspective. At some point, you need to make a decision whether you want to leave your paper diaries and move to e-diaries, and then you read the ROI articles and you look at what are the benefits. I think what we hear here is that from a scientific perspective, we are all sold. We've seen what happens to the data. And once you've made the transition, you have the possibility of looking at your own data. And we also have data confirming that we could reduce the sample size by 15%. And then it's the question, do you dare for your next trial to actually trust that? And once you've done that, I think that we don't have to argue every time we do an ePRO study, because then the data speaks for itself. So it's almost like a process in the decision making.